Please welcome co-founder and managing partner of Oak HCFT, Annie Lamont, for an interview with President and CEO of Blue Cross and Blue Shield of North Carolina, Patrick Conway.
So we are super excited to have Patrick with us today. As you can see, there are only 2 chairs, not 3. We thought we would have Adam Bowler too, but I don't know, just when you thought the Trump administration's ethics department would be fully occupied, they decided that the former CMMI director should not be sitting with the current CMMI director as of last week.
I did tell Adam it's going to be a great job. I think he'll have a huge positive impact. When he was in the process, I said, the one thing that will happen is every once in a while, government will do something, you're like, what the heck, this is really stupid. And you'll be mad and frustrated, but it's okay. So,
yeah. Well, they're hitting him early with it.
Yeah. So his first week, he has a challenge.
Yeah, so we'll miss him, great entrepreneur. But the good news is it gives us more time with Patrick, since we only have 25, 30 minutes. So a few fun facts about Patrick. Longest serving CMO, HHS CMS, right? Mm-hmm. 7 years. Through 3 presidents, actually served under President Trump. Mm-hmm. You insisted on not being a political appointee, so might be interested to get into that for a minute. And the first physician to run a major blues plan, which is kind of incredible. And still a practicing pediatrician.
I am. So I take care of kids who get hospitalized. I volunteer, so I don't break any ethics rules myself.
Right.
At UNC Children's, taking care of kids and their families.
Yeah, cool. So why don't you tell us a little bit about how you got into government in the first place?
Yeah, so I did a White House fellowship in the Bush administration, which I had heard about from a friend of mine, worked for Secretary Leavitt, and then stayed on as his chief medical officer at HHS, at Health and Human Services. Then went back to Cincinnati Children's, where I led quality for large children's hospital that gets referrals from 50 states, 80 plus countries, led a large division, and then led our quality work. And then Don Berwick and Kathleen Sebelius actually asked me to come back into the chief medical officer role. When I left DC, I had said there were 2 roles I would think about coming back for. That was one of them, because my passion's around better healthcare at lower cost for people, and just an amazing run for 7 years. Public service is important, despite my joke about Adam, and maybe I shouldn't use the word stupid. You can tell I'm out of government now. I actually say what I think. Now some ethics person is going to email me, because I'm in my cooling off period, so I'm still connected. But in all seriousness, was a chief medical officer, then got to run CMMI for about 5 years, so was the second director. I guess longest serving there too, although there's only been 2 of us, and now Adam will be the third, and got to be principal deputy administrator with Andy, and then acting administrator for the agency.
Yeah, fantastic. And just so you know, I'll keep serving up a few questions to Patrick, but you can also open up the Health app. We'd love to get questions from you. So open up the app, open up Health, go to More, go to General Session, and then Q&A, and then you can put in your questions, and we'll be seeing the most popular questions up on the screen here. Fantastic. So you have 5 criteria for any new job. Can we talk about that?
I didn't see that one coming. I do. So my 5 criteria, 1 is family. So I'm married with 4 kids. Flew out this morning so I could be home with my kids last night. So lovely 7 hours to travel to get here. And 2 is impact, which has been the triple aim even before I knew it was a triple aim. So better healthcare, lower cost, great service experience. 3 is people, so the people you're working with. And I've had a chance to work with some amazing teams, including the current one at Blue Cross North Carolina. 4 is learning. So I've had a lot of different provider, payer, innovation space, and so have continued to learn throughout. And then 5, I actually added a little later, it's joy in work. And it's exactly what it sounds like. You actually have fun every day, or as many days as possible. Right. And so, that's really guided my career decisions along the way.
Yeah, fantastic. Good. So, as you're handing the mantle off to Adam, what are you most proud of, and what is most important to you that is maintained in terms and built on in terms of what you built?
Yeah, so I'd say a few things. Most proud that we really did shift the system, especially for Medicare, but I think across the board in a major way. So, when I started at CMMI, this was a team effort. We had 0% of Medicare payments and alternative payment models. So, where providers are accountable for quality and total cost of care, ACOs, bundles, advanced primary care medical homes being the three biggest, but there were more. By 2016, we actually reached what was President Obama's goal at the time, over 30% of payments in these alternative payment models a year ahead of schedule. That's over $200 billion. It was over 200,000 signed provider agreements across the country, agreements with states, providers, others. That's a huge shift. I was on a panel with Don Berwick recently, and he said he thought we'd had more positive health system change in the last 3 to 5 years than ever in U.S. history. I think he's right. He also said we have a lot more work to do, which lots of folks in this room can contribute to. I think a huge opportunity for continued innovation and improvement. And the last thing, sorry, long answer, but safety results. We had projects that literally saved over 100,000 lives, over 300 injuries, adverse events avoided. Things like next generation ACO, which saved 2% off trend, ESRD ACO about 6% off trend. 2 to 6% off trend for Medicare would change our country's financial trajectory. So I think Adam will do a great job building on that. I think certainly there's still a gap in some more consumer-oriented models, which we were starting to work on, where I think you could do that. You may ask me, I think there's still a gap in what I'll call smaller prototype innovative models where we could never really get that pathway going as much as I wanted.
Yeah, a lot of innovators here, and I told Patrick, I think one of the great frustrations of the venture community and the entrepreneurial community was that most of the pilots were done with not-for-profits. And we assumed when CMMI came into being that it would be the playground for entrepreneurs.
Yeah. I do think that is. I don't say regrets, it's like learnings, but I think whenever we did have some projects with for-profits, but you're right, there was this push to focus more in the nonprofit arena. I was often the one at the table saying we shouldn't limit competition. Whoever delivers the outcomes that you want, better health outcomes, lower cost, innovation, that's who we should partner with. So I think that was challenge number one. I think two, the CMMI process very early on, even before I started, got built similar to the rule writing process for the federal government, which is really long and laborious. Actually, I didn't share this in the pre. When I started, time from idea to model launch was literally about 3 years. There's no way that's the right answer. Right. We got where we could go idea to model launch in about 6 months. But from when I was at Cincinnati Children's, you could literally do, I want to test in this unit tomorrow with this company, this intervention. And so I think federal government has a challenge to get much closer to that, where you're doing smaller prototyping type tests, learning faster, implementing quicker. And the people in CMMI wanted to go there, but at least in the early years, the federal government was a little concerned about sort of letting that type of innovation happen out of the federal government.
Interesting. It's interesting because if you think the great thing about civil servants is you've got consistency from administration to administration, and sometimes we're really happy about that because things can only change so quickly and it's more stable. But then when you're trying to do something like this, it's probably harder to work through the system. And how do you change that? How do you do that?
So a couple thoughts. Thank you. That's a great question. So one, recruiting for CMMI, and when I started, we had about 70 or 80 people. When I left, it was about 400. And it was Adam tweeted this the other day. He's on Twitter now, by the way. I'm following him. It is an amazing team. Yeah. So I recruited people from all sorts of industries. Our team recruited people from all sorts of industries. And I gave literally everybody the same pitch, which was, you're going to work really hard and we're going to pay you less money, but you can change healthcare in America. Yeah. Do you want to sign up? Yeah. And a lot of people signed up. And so we recruited some civil servants who had been there a while, which you need because they know a lot of things that are critically important, plus a lot of what I'll call new talent from all kinds of industries. It's an exciting group. I'm actually in Blue Cross, North Carolina doing similar things where, we have a great team, and then we're recruiting some key additional people into that team, including from different industries. So.
Okay, good. We've got a few questions here, but one that's relevant to this. So, something that I actually believe in at some level, MA for all. Yeah. How do you think about that? And barriers may not, versus single payer.
Yeah.
But, yeah.
Well, now being on the payer side, I'm very supportive. So actually, I will answer that question, and then I'm going to sort of pivot it back to Blue Cross North Carolina, if that's okay. So I think the beauty of MA for All is, you have aligned quality incentives and cost incentives, but then there's a lot of innovation underneath that. And honestly, if you think about a lot of the innovation center models, next generation ACO looks like you're paying providers like MA plans, essentially. And we had a lot of waivers, telehealth waivers, how they document waivers, et cetera. So, it was actually mimicking a lot of MA attributes, if you will. So I think MA has a lot of benefits. If it's all right, I'll pivot a little bit off that to talk a bit about sort of North Carolina, because it also has some attributes of MA of caring for people for a long time. So Blue Cross North Carolina, we insure the majority of people in North Carolina. In some instances, like in the individual marketplace, we're 95% of the market. And most of them, for the majority of their lives. And we're in Medicare Advantage now, we're in commercial, individual marketplace, or Obamacare, and we're going into Medicaid. What I love about that is it is, large state, but very contained, and you're able to innovate and test new things at a much more rapid cycle. Somebody asked me the other day, what did I miss and what did I love about the transition? CMS is a scale like no other, 140 million people, so, I missed that part on some level, but what I love about North Carolina, still big scale, but you can go really deep and you can learn so much faster without the sort of encumbrances that sometimes happen in federal government.
So you have an interesting dynamic in North Carolina with, sort of 5 major providers being a majority of the market, right?
Yep.
How do you deal with that? I know you talked about partnership, but how do you get incentives aligned? So.
Yeah, so great question. We do have 5 systems, or about 50% of the total market. We're in actually conversations with all of them right now about a new model that we haven't branded yet. I was about to give you the name, but we haven't officially branded it, so I'll wait.
Oh, come on.
We're looking at Blue Vanguard, but I'm like, is there anything better? But I like Blue Vanguard too. But I'm not a brand expert. But it really is a model where you're in partnership with the system. So what we're saying to them is, we don't want you to be in fee-for-service. We want you to take this alternative pathway with us. The good news, many of them in Medicare are in ACOs and other things. And we say, we're going to jointly be accountable for quality and total cost of care. And by the way, if you go, we want you to move into 2-sided risk, so it's truly accountable over time. And by the way, as you take on risk, if you go into something that looks like next generation ACO, we'll do some, what I think are really innovative things. We're considering, would we turn off all prior authorization? Which I'll say, when you say that to a provider, they get very excited. And your documentation, other than risk coding and other things we need for other reasons and STARS measures, we're not going to worry about how you document, because just care for patients. Telehealth and aspects like that, once we're paying for a population, use it however you want to. Which I think for people in the audience, whatever space you're innovating in, those kind of partnerships I think are really exciting, because now you've got a provider and a payer that are no longer setting all these rigid rules. They're just saying, we want better health outcomes at lower cost and a great customer experience. We could talk more about customer experience if you want. And how do you innovate to achieve that? Can I riff on customer experience for a second?
All right, you can do that. I wanted to get into the blues, but go ahead.
And then you go to the blues. So our net promoter score is in the teens, which actually is really good for a health plan, sadly. Yeah. If you get to 30s, you're like, no one's better. And so what we're challenging our team is how do we get to the 30s? And eventually, could you be 60? Is it possible to be a health plan that's so tight with its customers and a new experience that it's a 60
amazing.
Net promoter score? So I don't know if we can do it, but that's the journey we're on.
Cool. So you're new to the blues.
Yes.
Can you talk a little bit about the association and what might need to change in the future and what the dynamics, and what were you surprised about?
Yeah, so they give you a little blues fraternity pen. Just kidding, but it kind of feels that way. I think the blues system has a lot of potential if it moves past, if as a system we move past a traditional health insurer. So the beauty of it is, we insure over 100 million people, so almost the scope of CMS. We are mission driven as a unit. And I think you've got leaders like Mark Gans, who we partner with Echo and investments that we do, and Paul Markovich in California. I think you've got a number of leaders who really want to drive change in the system. And then I think that the question is, and others, so none of my colleagues get upset with me. The question is, how do you shift that entire system to think beyond traditional health insurance and really think about innovation, data and analytics, the customer service experience, investments that are outside of traditional health insurance. So, I think that's our collective challenge as an association, as a system.
Who and how should you pay for social determinants? How do you think about that?
Yeah, so I'd say we try to deal with, first, as you know, social determinants, major driver of increased costs and lower health outcomes. We think about it in two major ways. One is from our foundation and community giving arm. We actually gave the largest investment in the company's history, $50 million last year, into social determinants, early childhood in North Carolina, opioids and mental behavioral health, so a few select issues. And I think we'll continue to see those kind of investments where you're investing really in the infrastructure, including some data and tech investments actually with the state around social determinants. And then as we go into Medicaid, but also in commercial and Medicare, we want partners that address social determinants. So we're talking about with primary care providers about whether they're current in North Carolina or entities that could support or enter North Carolina that think about transportation, housing, food insecurity, and it's part of the model because it's part of the health experience for people. So I think we made some progress in that area. I think that's a good example of an area that we've seen some models like a ChenMed or others that do much better on social determinants. So how do you partner with people to bring that more broadly across the country?
Do you think about partnering with the state of North Carolina?
We do.
Yeah.
The Secretary of Health there used to be our Chief of Staff at CMS, so that helps. We know her. Secretary Mandy Cohen, who's terrific. We are doing a lot of partnerships with the state. So we're partnering in social determinants. Medicaid, there's not an RFP out yet, but we're transitioning to Medicaid managed care, and we want to be a big part of that. We work with all the state employees, which is 550,000 people in North Carolina. We insure them. So a lot of levers to drive change at the state level.
Let's see. So one of the things you talked about, because you've come in very quickly. You want change to happen fast in North Carolina, which is an oxymoron maybe, but.
I hope not.
And as you think about the things that can make the most change, I know you have a huge emphasis on primary care.
Yep.
What are you doing? How quickly do you think that you can have an effect? How do you think about it? I'm passionate about primary care driving downstream costs.
Yeah, and I know we have multiple colleagues we've talked to in that arena. Yeah. I'd say a few things. First, high-level goals. We talk about better care and health outcomes, lower costs, great service experience. Underneath that, there's a provider bucket where the three major areas are deep provider partnerships. So moving everybody to these type of alternative payment model, we're in it together. Including risk on all sides, partnerships. Two, we talk about primary care, where I think, I know you know this, but you want 24/7 access, you want telehealth enabled, you want the ability to address social determinants, you want a real focus on higher quality and lower cost, and we're similar to Medicare. We spend less than 10% of our total spend on primary care right now. I think that may change over time. But they control 80+% of the cost, depending on how we count. So there's good evidence, both in this country and others, high quality, amazing primary care, better results for people. Second major area is mental and behavioral health, where we're looking at.
So
yeah.
How do you, as the payer, how do you drive that? How do you make sure that the patients show up in primary care and it's incentive, the system is incentive?
No, it's good. So we're looking at it, and this, I don't know how deep you want me to go, but we're thinking about all our, it varies there's some primary care that's, great for Medicare, but doesn't do others. So first, there's a basic segmentation of Medicare, commercial, Medicaid, and then patient population. So we've got some partners we're looking at that I'd say are more in the concierge type care, where it's like a very high level of access and added benefits. We've got other partners we're looking at that I'd say are very, like, we care for really sick people, and we do it really well. So send us the sickest of your sick, and we'll take care of them, whether it's in Medicare, Medicaid, or others. And then we're also looking at some enablement capabilities. So could we have a partner who brings capabilities to rural providers, as an example, that they're never really, it's going to be very challenging for them to build all those capabilities on their own.
We have a lot of questions from the audience. How do you define healthcare quality? And obviously, the government has their own, and you get incented and rewarded, and so people drive to those metrics. But how do you think of it beyond that?
Yeah, so I'd say a few things. So it is true. I mean, I was responsible for a lot of the quality measures at one time for the government. So I always tried to move to more outcome measures, less process measures. We actually did make progress there. And then sort of aligned measures across payers where we made some progress but really need to do more. Outcome measures whenever possible, including patient-reported outcome measures and health outcomes. Process measures only if they have a real clear tie to outcomes. And then I think experience measures, do matter. So whether it's CAP surveys or other measures of experience, I think healthcare, like other services, should have an experience component. And then obviously cost, we look at total cost of care, and then for things like bundles, episodes of cost.
Okay, so exchanges. With stressors on the ACA exchanges, would a public option with incentives to Medicare Advantage plans fill access needs and propel innovation?
Real easy question. That won't get me in trouble. So I'd say a couple things there. One, in North Carolina, we're in all 100 counties, and we're the only insurer in a lot of those counties. Our goal is to have, across business lines, but even more important in individual, as low of premium increases as possible. And we've actually set a goal that I talk about publicly of less than 5% or less, which most insurers are reticent to do. I can't promise that'll be the case. 85% of our costs are medical costs, but I think 5% or less is tolerable. And if we can get a negative premium, I'd take it any day, but 5% or less. And then, I think for Bexar counties, the current administration will have to decide how do you want to deal with Bexar County issues. And I think, public option or other things are one way. The other way one could deal with Bexar counties is, cross-state line issues, or even historically sort of talking to insurers and trying to get them to fill in the Bexar counties. So I think remains to be seen.
Vertical integration, hot topic right now. Possible Humana, Walmart, and we've got CVS and Aetna.
Yeah.
How do you think about that in your state and then broadly?
Yeah, so a couple thoughts. So one, North Carolina is an interesting market. So we've got every major national payer competing for share, including one of them when I got the job said, congratulations on the job. We're going to try to beat the blank out of you in North Carolina. I was like, thanks. It's a top 5 market for us. I think on the integration point, and they all vary a little bit, as you know. I mean, CVS, Aetna, I think the question is, can you, and I said this publicly once, and then one of them called me not so happy, but can you actually integrate well and get the full value out of that relationship? But, it's got a PBM play to it, as you know. It's got a consumer-oriented play and is interesting. Walmart, Humana, I think the first question is it really real? If it is really real, once again, you've got a consumer combined with the Medicare Advantage population. What I say to our folks, I get asked by our employees all the time. You might think I say this is a bad thing, that these things are happening. I actually view it as overall positive. It forces change. You didn't ask. Amazon, Berkshire Hathaway, JP Morgan.
Right.
My biggest takeaway from that is they're so upset with the current system that they're willing to take it on by themselves, and remains to be seen what that actually means, but we should listen to that. Right. If you've got big employers that are that upset with the current system, we have to service those employers and the people they represent better because it's identifying a real problem.
Yeah. No doubt. I don't know. The screens have gone blank, so I think we're supposed to wrap it up. Any last comments you want to make, Patrick? But
no.
Thank you for being here.
Well,
appreciate it.
Thanks for having me. Really appreciate talking with you, who certainly one can learn a lot from. For the innovators in the audience, I guess what I would say is I do come at this from a practicing physician lens. for better or worse. But I think what I mean by that is we have people in our system each and every day that don't get the care that you would want. What we've talked about with our workforce is treating every member, every customer like family. And that is a very centering concept for people. Because if you think about it that way, you deliver better health outcomes at a lower cost and a great experience. And for us, it was, we had a child who, I won't tell the whole story since we're wrapping, but, was not getting a drug that was life-saving that they needed. We fixed it in less than 60 minutes. We process reviewed it so it never happens again. I called the family, the parents. And it was the hardest conversation I've had in a long time to listen to how bad our system, through no ill intent of anyone, what happened to them and their child. So I think at the end of the day, please innovate, please drive change, please drive better health outcomes at lower cost. We've got to go faster and we've got to go better.
Thank you.
Thanks
you,
a lot.
Patrick.
Thank you, Annie and Patrick.